Our doctors can advise patients or discuss with them treatment options and likely outcomes. But you know who they really believe is other patients who've gone through this. The other patient's voice is simply more authentic. It's not that they're not believing what, our doctors are telling them, but to hear the experience of someone else who's gone through it or is going through something similar to you has a level of truthfulness or authenticity that is more relatable and actually more encouraging to an individual. I was there, I got through it, you can too.
It's almost like mentorship, right? Like that's a thing.
It is exactly like mentorship.
Yeah.
In part 2 of this ongoing series, the exam room continues its conversation with Dr. Mary O'Connor, orthopedic surgeon and national leader in prevention-focused, value-based musculoskeletal care. This episode explores why patients are often more influenced by the experiences of other patients than by clinical advice alone, and why emotional readiness, trust, and peer support play a critical role in lasting behavior change. Dr. O'Connor explains how health coaches, community-based programs, and mentorship models help patients overcome barriers that knowledge alone cannot. Dr. O'Connor makes the case for an intermediary, non-surgical approach that prioritizes what truly matters to patients, whether that's returning to activity, spending time with family, or simply living without pain. This episode highlights why engaging patients at an emotional level isn't a nice to have, but a necessity for better outcomes, lower costs, and a more sustainable healthcare system.
It takes a lot of persistence and resilience and grit, I think, to change something, like your family always eats a certain way and they always expect this, and that's really brave. I don't know if most patients are that brave. There's a lot of barriers for them to make those changes. And I'm just wondering what else can we do as healthcare people to remove some of those barriers or to make them more open?
Well, this is where, like in our model, our health coaches are so important, right?
Mm-hmm.
Because they're setting those specific, small, incremental goal changes for the patient and encouraging them and listening to, what their barriers are. So they're providing that level of support.
Mm-hmm.
Now, that support can also happen, again, in kind of more of a group setting where you get the group providing this level of emotional support for these changes. The whole issue is that we consistently want to not recognize the power, the importance, the essential element of our emotional decision in making a change. Mm-hmm. We keep thinking that if you give somebody knowledge and you say, this is so important and this is the right thing for you to do for your health, they're going to do it. Well, we should know now that doesn't work, okay? What works is when we can get that person engaged at the emotional level, that they're emotionally ready to make the change. And we give them the support to do that. And that's what in the traditional system, I think we've really missed because we haven't resourced it properly. We haven't trained people on it. And the traditional system basically doesn't want to allocate the resources to pay for that.
Can you give the listeners an example of what that engage at emotional level looks like?
The way that we approach a patient coming into our practice to see us for medical care is we start by asking what matters to you. Let's say you come because you have knee pain. Well, that's what is the matter with you. We want to know what matters to you. And what matters to you is going to be influenced by who you are, by your values, by your background. And maybe what matters to you is you want to run a 5K in 2 months, but your knee pain is stopping you from training. So our treatment plan is focused on, let's get you running that 5K in 2 months. Or maybe you want to play with your grandchildren and you can't because it's your knee pain that keeps you from playing with the grandchildren. So the treatment plan is focused on, we want to address your knee pain, but that's not what really matters to you. What emotionally matters to you is you want to play with your grandchildren. So how do we get to that part? That's really the secret sauce. I'm like, we didn't create this what matters to you concept. That's been out there for a while, but it's just not, I would say, embraced at the level that it should be.
And there's not a lot of time, right? With our fee-for-service model, there's it seems like in the traditional sense, there's not a lot of time to find out, well, what matters to me. And maybe at the patient level, they don't really understand it either because I'm just sick and I'm having this symptom and I want you to treat it so I can go on about my business.
Okay, but that's what matters to you. You can't do your normal daily activities,
Yeah.
right? I mean, it's trying to get to what is it that the patient values that gives meaning and quality to their life, that by you addressing this musculoskeletal concern, you can help make that better, right? Because people make decisions based on emotion. We keep thinking that it's all data driven and intellectual, but we use data to support the emotional decision that we want to make. That's what we do. And so we have to focus more on how do we engage the patient at the level where they are ready to do the activities that are going to improve their health. Because in our world at Vori Health, in the musculoskeletal world, we know there's a lot of overutilization of surgery, of procedures, and those don't always help patients. And like, I'm a surgeon, so I can like say that, okay? Remember, every clinician has a bias based on their training. And orthopedic surgeons and spine surgeons, whether they're orthosurgeons or neurosurgeons, are not well trained in non-surgical care. And so when somebody goes to see a surgeon, there's almost like a binary assessment. You need an operation, or I think you could benefit from an operation, versus you don't need an operation. And if you don't need an operation, the surgeon's going to send you to physical therapy. I mean, the surgeon's like, what are you doing? Coming to see me further. I don't need to see you in the future because you don't need me, because I do surgery and you don't need surgery.
Right.
Okay. So that makes sense. And that's not a knock on the surgeons, because remember, surgeons do surgery. The challenge is in the musculoskeletal space. We've missed this intermediate step where the patient's getting great non-surgical care first and then being escalated to the surgeon when appropriate. I tell people all the time, in our company, we're not anti-surgery, we're just anti-inappropriate surgery. So our goal is to help that patient improve. And first, starting with good non-surgical holistic care, where we're using that biopsychosocial model, right? Looking at behavior change and anti-inflammatory diet, sleep, decreased stress, anxiety, all those things, right? Because we know we have a better chance of helping you get better without an operation. But some people still need surgery. That's like not a failure. It's just, let's just make sure that it's clinically appropriate for you to see the surgeon as the next step.
If we had said patient with knee pain that went to their primary care physician, like what would you want to say to them, to the primary care physician, about how you would suggest that was handled?
I have huge admiration and respect for primary care physicians. Like, I could not have been a primary care physician, because you have to be able to manage so many conditions. And part of the challenge for primary care physicians is that they don't traditionally have a lot of training in musculoskeletal.
Mm.
So if you look at the background knowledge that they have on MSK, it's usually not that in depth. Now, if a primary care physician has done a sports medicine fellowship, they obviously have a lot more knowledge.
Right.
But in general, we will say to primary care groups, we at Vori are your intermediary. Let us see that patient. We are the non-surgical MSK specialist. And particularly for groups that are in value-based care arrangements, that's a very attractive system because we will decrease the rate of surgical referrals because we're focusing on appropriate referrals to surgeons. We decrease the rate of advanced imaging because a lot of advanced imaging is not required, but ordered by a PCP. And again, I'm not trying to denigrate in any way PCPs, but sometimes they order an MRI to know, quote, know if they need to send the patient to the surgeon. And the problem with that is that MRIs have been well shown to not necessarily identify the reason why the patient is having pain, particularly MR imaging of the spine. So just because somebody has back pain or neck pain and the PCP orders an MRI, like basically anybody who's over 30, that MRI is going to be abnormal. It's going to show like maybe they've got a little early arthritic change or a little disc bulging or a little this or a little that. We know those findings on MRI actually poorly correlate many, many times with the reason why the patient is having pain. So this is why the current guidelines will say, for example, for patients with low back pain, that you don't get an MRI right away. The patient first tries physical therapy and other non-interventions before anyone would consider ordering an MRI in the absence of what we would term red flags, right? All of a sudden, if somebody's got their foot doesn't work anymore, like, okay, that's a red flag. They actually need an MRI like today. I'll give you one more analogy. A primary care physician does not refer a patient to a cardiothoracic surgeon when the patient has heart disease. A PCP refers the patient to a cardiologist. The cardiologist does the non-surgical management and treatment of heart disease for that patient. If the patient needs surgery, the cardiologist sends the patient to the cardiothoracic surgeon for cardiac bypass surgery. In the MSK world, we are the cardiologists. We are the non-surgeon MSK specialty practice that serves as that intermediary because a lot of patients don't actually need to see the surgeon and have surgery who currently undergo surgery. And that's expensive for the payer and it's expensive for patients because patients nowadays have out-of-pocket expenses. And it subjects that patient to postoperative risk because there is absolutely no surgery that any surgeon can do that does not put the patient at risk of a postoperative complication. Regardless of how brilliant a surgeon you are, there's always that risk. And patients have complications, and they can be harmed by those complications. And those complications cost more money to treat. So the further upstream we get, let's give that patient great non-surgical care and only send them to the surgeon if they need to see the surgeon. We will avoid all of this bad stuff happening because of inappropriate surgery. I mean, if we're not fundamentally helping patients, then we have no business doing what we're doing. But we have to recognize that we need to help patients more effectively in a way that is more financially responsible, not just for the patient, but for the whole healthcare system and the whole country. Because we can't we can't afford what the current system.
Yeah.
When families pay $5,000 or $8,000 out of pocket max for medical expenses in a year, plus whatever they're paying for their monthly premiums, I mean, it's nuts. How do regular families manage this?
My dad had to go have a procedure, and so I drove him there, and they had given him diazepam to take, and so he took it, and I drove him, and we checked in, and the gal behind the counter says to my dad, well, do you want the relaxation medication? And I said, well, he took the diazepam. I'm like, well, like, Dad, do you want that? And she's like, oh, if he wants it, it'll be an extra $150. And I said, so that he can feel relaxed and comfortable, like it's going to be an extra $150 charge. And she's like, yes. And I was like, okay, so this is where we're at. My dad is retired. He's not wealthy. He's on Medicare. Okay, so this is just another stark reminder of
That's like wrong on so many levels. I can't even I don't even know where to start. I'm like angry in the moment for your dad listening to this story that is nuts. That's nuts. And then to make matters worse, they spring this on him at the time that you show up. Again, so wrong on so many levels.
As we wrap up today's conversation, one thing is clear: improving health isn't just about treating symptoms, it's about understanding people. In the next part of the series, we'll continue exploring how community, connection, and patient-centered care can change outcomes and create a more sustainable healthcare system. Thank you for listening to The Exam Room, a podcast where we dive deep into the world of value-based care, patient-centered healthcare, and improving health outcomes with your host, Dr. Rhiannon Windsor. Dr. Windsor is a certified surgical technologist, healthcare educator, and the manager of training at VB Care Network. With almost 30 years of experience in healthcare and instructional design, she's spent her career helping clinicians and care teams optimize patient outcomes. We'll see you next time.